Hey, you guys. So we're just going to finish up the lecture on treatment. First of all, we talked about different kinds of therapies. We talked about, psychodynamic. We talked about cognitive behavioral, and humanistic. And behavioral. Those were kind of the main therapies we discussed. But here's something I just wanted you to think about. What makes therapy successful for an individual? Well, first of all, the therapeutic relationship is really, it's significant. You have to feel comfortable with your therapist. You really do. And so let's say there comes to a time in your life where you're feeling like, I really need to talk to somebody about whatever's going on. If you go into, it's already a little scary going into a stranger's office and you're supposed to talk about your feelings. Totally get that. And that is a very normal feeling. But once you're in the office, after the first session, think back. Did the therapist make you feel comfortable? Now, I will tell you just what to expect after that first session is you're going to feel a little exhausted, but you also might feel a lot better. Sometimes it can also open up some stuff, and so you feel kind of raw emotionally. But again, do you feel like you clicked well with the therapist? Do you feel like they heard you? Because really, that therapeutic relationship is so key for it to be successful for yourself. The person, you need to feel like they care and that they respect where you're coming from. Again, there's a chance they're going to point out some unhealthy things you're doing, but you don't want to feel judged by them. Let's put it that way. Your therapist, they need to have a caring attitude. They need to be able to listen to what you have to say. They need to be sensitive to where you're coming from. Also, the client, that would be you if you go into therapy. That person needs to also have motivation. They need to be actively involved. There's kind of a saying from therapists that says if the therapist is working harder than the client, then it's not working. The client has to be willing and ready to do the work. And they really need to be emotionally and socially mature enough to do the work. Do we do children's therapy with children who are not mature enough to talk about feelings? Yes, but we usually don't do talk therapy. We do play therapy. For a child to feel emotional, or for a person, to be emotionally and socially mature, they might have to talk about some very sensitive issues and not giggle through them, okay? I've had parents bring their teenagers into my office, and I'm going to move my camera a little bit so you can see. This is what I get from the kid. It's very evident they don't want to be there. And in that, I'll ask the parent to leave after the initial introduction and paperwork signed and all that fun stuff. But I ask the kid, okay, so you're here because your parents wanting you to be here? Yeah. Okay, so how do we not be here? I don't know. Okay, well, do this deal for me. Give me 3 sessions. And if after 3 sessions you still don't want to be here, I'll let your parent know, and you don't have to come back. Can I tell you that has worked again and again for me, because what happens is in that 3 sessions, usually the teen realizes, number one, I'm not the bad guy. It's not really that scary of a situation. Their discomfort is about their nervousness. And I've even had a couple of them go, at the 3rd session, I'll check in. So what do you think? Do you want me to tell your parents or that you don't need to come back, or do you want to continue coming? And I've actually had a couple go, yeah, I guess I need this. And they came to that conclusion themselves instead of having a parent drive them in there or drag them in there every week. Now, here's the other piece. So I've had those kids who I can't reach because they're just not motivated. They're not ready. And I've told their parents, you know what? They're not going to go where they need to go. They're not ready. They're not motivated to be here, and it's a waste of your money. And in time, hopefully they'll be ready to come back. Give me a call when they are. So again, the client has to want it, okay? Okay, so let's talk about biomedical therapies. The first one is psychopharmacology. Big word. It's a college word. Basically, it's a study of effects of drugs on mind and behavior. So in psychopharmacology, there are medications that they use to help with psychological or with mental illnesses, okay? Does every person who goes to counseling, do they need to be on meds? No, they don't. And so let's just make that clear. But for some, it really helps. So let's talk about those a little bit. Antipsychotic drugs. Well, of course, if somebody is seeing things that aren't there or hearing voices that aren't there, and of course that can produce paranoia and a whole string of other issues. So antipsychotic drugs, basically, I'm just going to tell you right now, you do not have to know, hopefully this works, you do not have to know any of this part, and you don't have to know the name of them, but just if you're curious, thorazine and clozapine are two of the medications that are used often for antipsychotics. But basically, antipsychotic drug, it's there to block and sometimes occupy the receptor sites for certain neurotransmitters and help a person get rid of their psychotic issues. Okay. Oops. Antidepressants. That's probably one of the more popular in that one, and anti-anxiety medications. Antidepressants, of course, we talked about in depression that it often feels like you're in a pit, right? Well, sometimes an antidepressant is it the end-all answer? No, it's not going to get a person completely out of the pit, but I put it to like giving them a step stool or a ladder. It just gives them a boost so they are then able to do the work themselves. So most antidepressants work by increasing the availability of neurotransmitters, which elevate arousal and mood and appear scarce during depression. So again, antidepressants, they're not the magic pill they're not a magic happy pill, but they are there to help people, just give them the boost that they need in order to do the work of getting out of the pit themselves. In fact, studies show us medication on its own, it's okay. Counseling on its own, it's okay. The combination of the two tend to be the most successful to help clients overcome their depression. Okay, now here is one that you probably haven't heard of for a very long time, if ever. Electroconvulsive therapy. It was very unpopular for a while. It was very popular in a long time ago. In fact, we did it probably more than we should have. If you watched A Beautiful Mind, you saw some electroconvulsive therapy being taken place there. So again, it's something that was done a lot back when we had a lot of mental health hospitals in our state. It was seen as a very viable treatment. Well, it's still seen as a viable treatment, but after a lot of treatments have not worked. Basically, if a person struggles with, let's say, medication-resistant depression, which that it exists, then they go on to the next state, which is trying these other therapies like electroconvulsive therapy. One that I'm not going to talk about, I don't have a slide for, but it has to do with magnets. They put magnets on their head, and that actually has been seen as being very successful. How electroconvulsive therapy is different than it was historically is historically you were not put out. Now they are put to sleep, and the patient does not really, they have no ill effects from the actual procedure, like it's not painful because they're out, but it is very effective for quick relief of symptoms of severe depression. and it's usually often also goes with medication. It may have some cognitive side effects. You can have some memory loss because of it. And it does tend still to be a controversial treatment. Psychosurgery. Again, we don't do that often anymore, but it is historical. Surgery that removes or destroys brain tissue in an effort to change behavior. Probably the most famous kind is called a lobotomy. Very rare now, but it is a psychosurgical procedure once used to calm uncontrollable emotional and violent patients. Years and years and years ago, we're talking hundreds of years ago, one thing that they would do is they would take a sharp object, put it through the eye socket, and move around some brain tissue up front. It's much more humane now, but again, it's not something you see often. So I'm going to have you watch this quick. It's about an 11-minute video about the history of lobotomies. Again, it's really not done anymore because we really have come so much farther in our knowledge about the brain, but just take a look at it.
I will perform transorbital lobotomy on 10 patients within an hour.
In the 1930s, a new brain surgery, like the one portrayed here in the movie Francis, was brought to the United States, the lobotomy.
Only a little more dangerous than operating to remove an infected tooth.
It was performed on mentally ill patients all over the country.
Lobotomy gets them home.
Hailed by the media as a miracle cure.
Life magazine, the New York Times, Time magazine, they loved it.
Lobotomy was felt to be mainstream science. It wins the Nobel Prize.
But more than 40,000 surgeries later, the brutal truth about lobotomy would come to light.
They were basically going in and mushing around brain tissue, and unfortunately, in many cases, leaving patients worse off.
7 decades later, a look back at the lobotomy story shows how far our understanding of the brain has come, and how far we still have to go. In the early decades of the 20th century, people struggling with mental illness had few options.
Families were at their wits' end, didn't know what to do with people who had lots of mental symptoms. Institutions were very overcrowded, and the treatments were very, very difficult, like hydrotherapy, where people would be immersed in water, insulin therapy, where the doctors would make the patient's blood sugars go down to 0 and they would have seizures.
In 1936, a new surgical technique called lobotomy began to be used. The experimental procedure, which partially severed the frontal lobes from deeper parts of the brain, was said to calm and even cure those struggling with mental illness.
Dr. Walter Freeman and Dr. James Watts, who was a neurosurgeon, were claiming that they had great success, that they were restoring a good life to people who had been suffering, and they had become famous.
One of Freeman's many skills, was cultivating the media, and they reciprocated with a lot of very favorable coverage. Miracle cure to the brain, cutting the brain cures the soul. The media was all over it.
In 1941, Joseph P. Kennedy, the patriarch of that prominent political family, read about the surgery and contacted Freeman and Watts about his eldest daughter, Rosemary.
Rosemary was slower to walk and talk. As she grew, it became more and more obvious that Rosemary could not really move beyond, say, a 3rd or 4th grade educational level.
Being at the table, she wasn't up to the complicated conversation we'd have, other political discussions.
In her early 20s, her mental health issues were really becoming a problem. The tragedy is many other doctors at the time recommended against this procedure. They agreed that it was too experimental.
But at the age of 23, Rosemary Kennedy was lobotomized. The surgery did not go well.
They cut too deeply into the brain fibers, and Rosemary became disabled.
She did eventually regain her ability to walk and talk, but She lost a lot of what was in her personality. There should have been a terrible setback for lobotomy. It wasn't.
With Rosemary Kennedy's failed surgery hidden from the public, Freeman would ultimately break with his surgical partner and take the procedure even further.
The simpler approach to the frontal lobes through the roof of the orbit.
Inspired by an ice pick from his kitchen drawer, Freeman would use a surgical pick to enter the brain through the patient's eye socket. He claimed that this could be done by anyone, anywhere, in a matter of minutes. And to prove it, he took his new procedure on the road.
Now, these things that were being done were nothing like what we might think of as modern evaluation of treatments, like a randomized controlled trial. These were just patients who were sick with mental illness, who got a lobotomy.
And it would be used for a whole host of ailments.
Hallucinations, obsessive behaviors, feelings of depression and suicide, soldiers returning from the theater of war with anxiety and behavioral problems, people suffering for what was then called intractable pain.
Arguably, one of those patients was Anna Ruth Channels. Channels had suffered from severe headaches for several years, and Dr. Freeman was sure that a lobotomy was the cure. Carol Duncanson is Anna Ruth's daughter.
Walter Freeman promised she would just be happy. Everything would be fine. And who wouldn't go rah-rah for that when you're hurting so badly?
Dr. Freeman lobotomized Anna Ruth when Carol was 3 months old, and in a cruel twist of fate, her headaches were gone, but so was almost everything else.
When they brought her home, she did not know how to do the activities of daily living, even the most basic things like toileting and bathing. My aunt taught her from the very beginning. She wasn't the mother that I would ever describe as being motherly.
Carol says, because her mother was unable to care for her, that she and her sister would spend part of their childhood living in a series of foster homes.
I'm told that Dr. Freeman went to West Virginia and interviewed my mother after the lobotomy, and that he considered her outcome excellent. That's probably the most insulting thing I've ever heard.
In the mid-1950s, treatment for the mentally ill would begin to change dramatically as antipsychotic drugs came on the market.
They weren't perfect. They had a lot of side effects, but they worked for a lot of people, which left lobotomy in an interesting place. I mean, why would I burrow into someone's brain if I don't have to? But some still felt that lobotomies were indicated. One of those people was Walter Freeman.
There was a number of children who received lobotomies at Freeman's hands. He recommended lobotomy for a young boy who was having trouble in his family getting along with a stepmother.
In 1967, Freeman would be forced to stop performing lobotomies when one of his patients died while having her third operation. In all, he had done more than 3,500 surgeries in 3 decades. He died in 1972, but his radical procedure had taken hold in popular culture.
There's only one little operation they perform here. It's on the brain. It's called a lobotomy.
I think the way culture has dealt with lobotomy might be in sort of a simplistic way. Evil doctors experimenting on patients and creating all this havoc and disruption. A great legacy of lobotomy would be to understand why lobotomy was so exciting at the time. People were enormously upset about the mental illness that they saw that they couldn't treat otherwise. They were excited about the possibilities of new technology. I think we can see how many of those factors are still at play today.
While people struggling with mental illness now have more choices, from new medicines to the more unconventional, like the use of LSD for post-traumatic stress disorder, for some, the treatments still don't work. But with the Brain Initiative, scientists are hoping that advancing technology will help them understand the brain in ways once thought unimaginable.
President Obama unveiled a $100 million initiative today that seeks to map the brain in unprecedented detail.
We probably know about 1% of what the brain is doing. The brain is incredibly complex, has 100 billion neurons, untold trillions of connections. So particularly when it has to do with higher cognitive functions like feelings and thinking and emotion, We really do not have a very good understanding of that.
At Massachusetts General Hospital, doctors are using a surgical technique called deep brain stimulation, or DBS for short, on patients with untreatable psychiatric disorders, including a severe form of OCD.
What do you feel?
A 7.
A 7? Okay, can you put an adjective to it?
It's a happiness.
Okay.
While surgery is not without risks, doctors say DBS is largely reversible. A pacemaker-like device is implanted with wires that send electronic pulses into targeted areas of the brain. It has successfully controlled tremors in Parkinson's patients and has been tested on patients with untreatable depression.
When I first met Liz, her affect, or the way her face looked, was just very blank, very sad, even had trouble making eye contact.
Liz Murphy's anxiety and depression had become so debilitating that one day she just got up and left her job.
Walked out and I never went back to the office and just went off the grid totally. I was just a complete shutdown.
The charging, it's fine.
In 2006, Murphy became one of the first patients to undergo deep brain stimulation surgery for depression. The surgery lasted 8 hours. Once the electrode was implanted and turned on, the doctors delivered a small amount of electrical stimulation.
Then finally I felt something, and it was remarkable, actually. Within 2 to 3 months, I started walking my dog again. Being able to get out of bed in the morning and getting showered and dressed, and they sound like small things, but I didn't do those things very well.
Our goal is to make very sick patients better. So if we have a safe therapy that takes someone that is so depressed that they can never leave the house and give them their life back, how can you say no to that?
While Liz Murphy was helped, some other results for depression have been less promising. Doctors are now in the early stages of experimenting with a new, more advanced device that responds to each patient's mood.
We realize we're on the cutting edge of these treatments for psychiatric illness, and because of that, we're extremely careful. There is a dark history of psychiatric neurosurgery. It's now been almost a century ago, but it still overhangs our field. But I really want to emphasize how far we've come.
Our challenge, I think, as a medical community is to not get over-involved in the fact that it's psychosurgery. Let's try to evaluate it scientifically as best we can.
So as you can tell, lobotomies have a sordid history, but what's exciting about that video is that there are so many different treatments that they are still developing. Remember when we talked about the hand, psychodynamic, cognitive, behavioral, humanistic, biological. Do you remember why we used biological as our little pinky? It's because we still, they said on it, we only know about 1% of what the brain is doing, but we still have so much more to learn, and they are learning it. That is the cool thing right now. So I don't know if you've noticed something, but we actually have gone full circle here. When we looked at the hand in our very first chapter we looked at in Psych 101, we talked about all the different perspectives. Guess what we've been talking about when we talk about therapies? We're talking about the different perspectives. And so that's the part I just really want you to take note of. That, the hand, it was a fun little tool to use for learning about the different perspectives, but we've come back to it. That treatment through psychodynamic, treatment through cognitive, behavioral treatment around relationships and humanistic psychology, biological kinds of treatments. So next week we're going to talk about our very last chapter, and that is social psychology. And so I hope that you will join me next week when we talk about that, because it's really interesting and exciting stuff. But we'll talk to you soon. I hope you have a great weekend.